Okay, this is Karen Crump. She's from Fort Hays State University, and she'll be presenting Content Section 1, a respiratory assessment for you today.
Thank you very much. As she said, my name is Karen Crump, and I have been shadowing Ms. Melton this semester, and I'll be shadowing her the rest of the semester. So we're going to give this a shot, okay? This is Chapter 29, Assessment of the Respiratory System. It's also a review of the anatomy and physiology. These are just objectives that I have to have. And they're good to look at. Okay. I'm going to start with the purpose of the respiratory system. The first and most important is to meet the body's needs for oxygenation and tissue perfusion, and to remove carbon dioxide from the body. Okay, and the upper respiratory and lower respiratory system are the two parts or components of the respiratory system. Am I speaking loud enough? The upper respiratory system consists of the nose, the sinuses, the pharynx, and the larynx. Okay. The nose is innervated by cranial nerve 1, or the olfactory nerve, and contains the receptors for smell. The septum that is located in the center is composed of 1/3 bone and 2/3 cartilage. The anterior nares are lined with skin and hair, and this helps prevent foreign bodies from lodging into the lung. The posterior nares open into the nasopharynx, and the turbines are the 3 bony projections that protrude into the nasal cavity. They help increase total surface area for heating and humidifying air before it enters the lungs. The parasinuses are air-filled cavities within the bone. They surround the nasal passages and provide renaissance speech and help decrease the weight of the skull. The pharynx is the passageway for both respiratory and digestive tract, and is divided into 3 parts: the nasopharynx, the oropharynx, and the laryngopharynx. Here's just another picture of the respiratory system. Probably on your in 544 or 545, you may have a picture of this or something very similar. Okay, the nasopharynx is located behind the nose and below the nasopharynx. Well, that makes sense. Okay, and it's used for the breathing and swallowing. The palatine tonsils are located at the side borders of the oropharynx. The laryngopharynx is located behind the larynx, which that makes sense, and extends from the base of the tongue to the esophagus. Can you see these structures on here okay? Okay. There's a critical dividing point where the food and fluid separates from the air, and that's where the passageway divides into the larynx and the esophagus. You can kind of see that right there in the middle. The larynx is located above the trachea and below the throat at the base of the tongue. It is composed of rings of cartilage. The thyroid cartilage, which is basically your voice box, the cricoid, which contains the vocal cords, and the 2, I'm not sure if I'm pronouncing this, arytenoid cartilages, which are attached to the back of the vocal cords. Inside the larynx, there's two different pairs of vocal cords, the false and the true. The glottis is the opening between the two vocal cords. And the epiglottis is a hinge-like structure that prevents food from entering the trachea when it closes over the glottis during swallowing. Okay, this is just a little clip. I can get it to come up here. Do I need to do anything to this to make it come up?
Sometimes it's control. Go up to your HTTP. Hover your mouse over it. When does it say anything? I don't think it's gonna play. Sometimes your link is blue, and then
Black here.
you do control click, and it usually takes you right to it. Once because if you've got that embedded in there. Sometimes it doesn't. It only works on the computer that it's been downloaded to.
Seriously? Okay.
You could minimize and if you know what it's called on YouTube and go there and watch it.
I actually have one.
Copy and paste it. We'll let you copy and paste it. Just go to last viewed or previous. There you go.
It's not gonna copy here. See? Oh, sorry about that.
That's okay.
That didn't work out too well. Actually, it was pretty neat. But
You can tell them a little bit about what it did show.
it showed the actual lungs breathing inside the body. Do you have it? Did it play on yours? Anybody with a computer?
No.
It didn't play?
Okay.
Okay, that sucks.
They can copy and paste it in there if they want to see it.
Okay.
I think what was it, like 2 or 3 minutes?
Yeah,
Something like
it's a
that.
couple of
It was just real
minutes.
short.
I didn't realize it was playing. Okay, so anyway. Okay, we're going to talk about the lower respiratory tract. That's composed of the trachea, 2 main stem bronchi, the bronchioles, the alveolar ducts, and the alveoli. And there's a picture on page 546. All right. This is a branching system that decreases in size from the trachea to the respiratory bronchioles. Gas exchange takes place in the lung for emphysema. The trachea starts at the end of the cricoid cartilage and branches into the right and left stem, main stem bronchi, where you can see that's the right and left right there. That's the pronounce it cornea, and in the middle where they branch. The right stem is slightly wider and shorter and more vertical than the left. So if you're going to, inhale something, that's usually where it ends up. Okay. They're lined with cilia like the nose. The bronchioles branch from the secondary bronchi and then divide into smaller and smaller tubes until they come to the terminal and respiratory bronchioles, which are the very, very small ones at the end there. They are less than 1 millimeter in diameter. And the terminal bronchioles are not involved in gas exchange. The alveolar ducts branch from the respiratory bronchioles, and the alveolar ducts rise from these. The alveolar ducts contain groups of alveoli, and this is where gas exchange takes place. The reason it's like that is because it makes a larger surface area for taking in and oxygen and letting off CO2. So Nature's amazing, huh? All right, the sinus consists of respiratory bronchioles, an alveolar duct, and an alveolar sac. In the alveoli, there are type 2 pneumocytes which secrete surfactant, which helps to, well, it prevents collapse, actually, of the alveoli or atelectasis. It's also a fatty protein, and it reduces the surface tension. This is just another picture of the lungs. You can kind of see the different lobes. That the right lung is larger and has 3 lobes, and the left lung is smaller and has 2. Of course, they're located in the pleural cavity. The top of the lung is the apex, and the bottom is the base. See your main stem bronchi better in this picture, how they branch. So since the right lung is larger than the left, where do you think most of oxygenation takes place? Anybody?
Right.
Right. Who said that? Okay. And you're
Connor.
Connor. Thank you, Connor. Okay, so actually 60 to 65% of respiratory function takes place in the right lung. And of course, the left lung only has the 2 lobes. The chest wall is innervated by the phrenic nerve, which innervates the diaphragm, and the intercostal nerves, which innervate the pleura, the ribs, and the muscles. Okay. That's about the lungs. Okay. There are 2 parts to the pleural. It's a smooth membrane with 2 surfaces that totally enclose the lungs. The parental pleura lines inside of the chest cavity and the diaphragm. And the visceral encases the lung surfaces. Okay. The pleura are lubricated by a thin fluid that's made by the cells behind the pleura, and it helps prevent rubbing, when you breathe. Makes it glide. And then you have your accessory muscles and your diaphragm, which are your muscles that are used in breathing. Okay. This is pulmonary circulation. This involves deoxygenated blood coming from the heart, becoming oxygenated, and going back to the heart. So we're going to talk about this a little bit. First, the bronchial blood flow is the system that carries the blood that's needed for the lung itself. So it keeps the lung nourished. And then the pulmonary circulation is the circulation that carries oxygen-poor blood to the right ventricle of the heart into the pulmonary artery, which carries it into the arterioles of the capillary networks into the alveoli. So you've got your oxygen-poor blood coming down into your capillary networks, and then it goes into your alveoli, and then gas exchange takes place. So your deoxygenated blood becomes oxygenated, goes back through the capillaries into the pulmonary vein to the left atrium of the heart. Then it flows to the left ventricle and back into systemic circulation. Does that make sense? Any questions about that? Okay. Also, contraction and relaxation of specific muscles. And the diaphragm causes the change in size and pressure in the chest cavity when you're breathing. Changes in the respiratory system related to aging. Everything happens when you age, basically. You have a decreased surface area in the alveoli. Decreased elasticity of just about everything. A decreased cough response, which of course that means you're not going to be getting enough, the phlegm, the sputum. Increased residual volume. Does anybody know what residual volume is? Somebody? Anybody?
The air that stays in the lungs. The air that stays in the lungs.
Basically, at the maxillary expiration, what's left in the lungs. Very good. Oxygen and CO2 exchange decreases. The muscles and vocal cords lose elasticity. And of course, this all causes an increase in hypoxia due to a decreased blood flow. Also, you just have a general decrease in mobility. I'm sorry. Decrease in respiratory muscle strength, increase in susceptibility to infection. The anterior posterior diameter of the chest wall increases. So you get a more of a barrel-like type of chest. The thorax becomes shorter. Post-scoliosis, am I pronouncing that right? Is basically an abnormal curvature of the spine as you age. Decreased chest wall elasticity, decreased mobility, and possibility of osteoporosis. Considerations: women have more bronchial hyperactivity and larger airways than men. Okay. Does anybody know what that means? Bronchial hyperactivity? It's like in asthma, you get, constriction. You can't breathe. Okay. It's an exaggerated type of constriction, and it's commonly seen in asthma. If you've ever seen anyone with an asthma attack. Okay. This also contributes to a more rapid decline in lung function as they age. Dark-skinned people have a false lower O2 sat by 3 to 5% pulse ox due to the deeper discoloration of the nail beds. So does anybody have any idea where else we could take the pulse ox besides the nails? Earlobe. I read the forehead, but I don't know how that would work really. I have seen those that do go in the ear. There are pulse ox that you actually just put them in the ear like a thermometer. So that might work. I don't know if they have that around here or not. Okay. Anyway, it's not a true reading. It's actually just because they have the darker nails. Like someone has dark nail polish on. Okay. Assessment. Okay, assessment. Besides age and gender and race, which you will need for determining the normal values for your patient, other information that needs to be gathered includes their work history. This is important for assessing possible contaminants in the air, such as industrial dust, chemicals, asbestos, depending on what kind of work they do. Like if you work in a coal mine, you're going to have like probably black lung. I mean, I know that they use more respirators now, but you're gonna have contamination. Home and community assessments. Do they live in an area where there's a lot of pollutants in the airs? What type of heat do they use? I know that I read that using wood heat is similar to, and I use wood heat, secondhand smoke, inhaling secondhand smoke from a cigarette. So I guess that makes a difference. Are they exposed to chemicals? Do they have a factory in the area that is releasing chemicals or harmful substances? Or animals, such as, are they allergic to some kind of danders? Or perhaps diseases that they may carry? Okay. You need to look at their hobbies. This is all stuff that you need to ask them before you even do anything to them. Hobbies expose them to irritants such as paint, airplane glue, woodworking chemicals like stripper, varnish, things you probably wouldn't normally think of as being harmful. You want to look at their respiratory history. Do they smoke or have they ever smoked? Do they use drugs and travel? Okay, if they do smoke or they ever had cigarettes, pipes, cigars, or marijuana, have they ever had passive exposure? Do they live with somebody that does smoke? Do they work with somebody that smokes? So if they do smoke, you need to determine their pack years, which is simply multiplying the packs that they smoke a day times the years that they have smoked. And this leads to airway obstruction. Okay. Do they use prescription or illicit drugs? Some medications have a cough as a side effect, such as ACE inhibitors. Can anybody name an ACE inhibitor? It's an anti-hypertension medication for blood pressure.
Benacar? Is Benacar one?
Is Benacar one, Ms. Melton? I don't think so. Lisinopril, Capitan, Vasotec, they're all ACE inhibitors. Okay.
That's content section 3.
I'm sorry. I
But
got
you are
confused.
correct. It is a side effect of ACE inhibitor.
Okay. My son takes lisinopril. Consider over-the-counter meds. Do they use any complementary? All are alternative therapy. Complementary therapy is in addition to traditional medical treatment, whereas alternative is instead of traditional medical treatment, like herbal medicines and teas, aromatherapy, acupuncture. I mean, and you could go on and on with that. But you need to be careful and make sure that you include herbs when you ask them, because a lot of prescription medication have interactions with herbs. And you can have a lot of adverse side effects when you mix them. So you need to be very careful about asking. A lot of people think, well, herbs are harmless, but they're not when mixed with some medications. So you need to be sure. Because a lot of times in the hospital, they don't even ask you about that. Also, there are some drugs that can cause permanent changes in your lung function, such as bleomycin used for chemotherapy. Okay. Allergies. Ask about allergies to food, dust, molds, pollens, and bee stings. The most common food allergies are milk, peanuts, shellfish, tree nuts, eggs, fish, soy, and meat, and that's not in the book. That's just something I know. You need to ask them what type of response they have. Do they have just a rash, hives? Do they have like a anaphylactic reaction? That's very important to know. And document that in the medical record immediately. because a lot of products have wheat and soy in them, and eggs. Okay. Travel. There are some geographical areas that have more diseases prevalent than the others, such as in the central U.S. I have heard of histoplasmosis? It's, okay. It's more prevalent in the central southeast, and it is a fungal disease caused by bird droppings. You know, it turns to dust and you inhale it. So that's more common out there and in Central America. So that's something you need to find out about, like where they live, where have they traveled out there recently, you know. My husband lived in California and he had histoplasmosis as a child, so at least that's what he told me. So anyway, and then you need to ask about their nutritional status, their current and past diet history. You can tell kind of by looking at them if they're eating what they should be eating, you know. And of course, ask about the food allergies. Family history and genetics. Okay, so you need to ask them about their family history for genetic conditions such as cystic fibrosis. Certain lung cancers are genetic. Emphysema is an alpha antitrypsin deficiency and can be genetic. And asthma can also be genetic. Ask them about infectious diseases. Do they have or have they ever had an infectious disease? Or their family members, such as tuberculosis. A lot of people that come from other countries, and tuberculosis is more prevalent in those countries. You know, you need to find out if it's in remission. Have they been treated for it? Okay.
Are any of you going on the mission trip? You get to walk through the open air TV unit.
Not me. Did you hear about the Ebola that a healthcare worker now has one?
Yes.
Oh my goodness. Okay. Ask about cough, sputum production, chest pain, and shortness of breath. You need to be chronological in your questioning. Ask them about onset. How does it start? How long does it last? What is the location? How often does it occur? What makes it better and what makes it worse? And what are the symptoms? Cough is the main sign of lung disease. So if they have a cough, inquire how long it's been present and when it occurs. Is it productive or non-productive? Okay, I'm getting ahead of myself here. Okay, now we're going to talk about sputum. Okay, if it's productive, about duration, consistency, color, and odor. I know it's kind of gross, but it's important to ask them because sputum can be clear, white, tan, or gray. If it's green or yellow, you could probably suspect it's an infection. Green is most likely bacterial, whereas yellow is generally upper respiratory infections, allergies, or maybe even from asthma. I don't mean to keep looking at you, but you're just right there. I'm sorry. I'll look at you. Smokers with chronic bronchitis typically have a mucoid type of sputum that is usually thick and white. Someone with pulmonary edema usually has excessive frothy pink sputum. With pneumococcal pneumonia, it's generally rust colors, which tells us what? Rust color probably has some, yeah, and probably since it's rusty, it probably is kind of old blood, right? Yes. Okay, a lung abscess. know that if you've ever smelled infection, it is not a good smell, right? Okay. Cancer or chronic bronchitis. This is a tough word to say. Hemoptysis, which is just blood tinged. TB, pulmonary infarction, bronchial adenoma, or lung abscesses. Have what they call gross blood, which is bright red blood, as opposed to, you know, when it goes through your digestive tract, it changes color. Have they got to that point yet? Okay. All right. The bronchial tree under normal conditions produces up to 3 ounces of sputum per day. Chest pain comes from a multitude of places. It can be from your heart, it can be pulmonary pain, or it can even be from your GI system. So you need to ask, you need a detailed description. Ask them what makes it better and worse. Pulmonary pain and nature varies, but it's common to hear them complain of a rubbing sensation. And of course, cardiac pain is a crushing, intense type of pain that radiates the arm, shoulder, and neck. Shortness of breath or dyspnea is a subjective experience. Okay, what do I mean when I say that? Connor?
Mm-hmm.
What does that mean when it's subjective? Okay, that means that only the patient knows. Only the patient knows. You can't measure that, his degree of shortness of breath. It's something that only he can tell you. Okay. So you need to ask them about it. Is it a slow onset? Does it occur over time, or does it come on, you know, abruptly, quickly? How long does it fast? Does it last, and does anything make it better? Do they have wheezing, crackling, or stridor? Does anyone know what stridor is? Okay. Stridor is and we're going to listen to this. Will that come up on this, do you think?
It should.
Okay.
If not, we have other links we can use.
Okay. It's a high-pitched sound, and it's pretty recognizable. Usually it's on inhalation and indicates they have an obstruction. It's pretty much what you would call in distress. So, does their shortness of breath interfere with their activity, daily living? And if so, how much? Ask if they have proximal nocturnal dyspnea, or PND, which is intermittent dyspnea at night that is severe enough to wake them up. Ask them if they have orthopnea, which is a shortness of breath when lying down and is relieved by sitting up. These conditions often occur with chronic lung diseases and left-sided heart failure. Okay, physical assessment. The nose and sinuses. Externally, check for deformities, tumors, and for symmetry of the nostrils. Observe for nasal flaring, which is more typical in children, but indicates that they are making an increased effort to breathe. When you look internally at the nostrils, look at the color, look for swelling and drainage, and any type of bleeding. The membranes of the nose are usually redder than the oral mucosa is. Okay, if they have allergic rhinitis, it would probably be a pale type of mucosa, bluish gray. Nasal polyps cause obstruction, and they're usually pale and shiny, and they are attached to the terminates. Perforation of the septum is something commonly seen with cocaine users. And you just, when you shine the light in one side, you can see it shining through to the other side. The pharynx, trachea, and the larynx. Okay, the posterior pharynx is observed above the soft palate and uvula. You need to look for color, symmetry, discharge, edema, ulcerations, that kind of thing. You inspect the neck, make sure it's aligned correctly, is symmetrical. See if there's any swelling, bruises, or use of accessory muscles. So if they're using accessory muscles when breathing, what would you think is going on? Maybe some difficulty breathing. They're using extra muscles. You need to palpate the lymph nodes for their shape, mobility, consistency, and tenderness. Tender lymph nodes are generally movable and are usually indicative of inflammation. If it's hard, firm, and fixed, it's usually malignant. You need to palpate the trachea for position, mobility, tenderness, and masses. The space on each side of the trachea needs to be symmetrical or equal. Some lung diseases cause the trachea to deviate from the midline to one side or the other. So for the trachea is pushed away from the affected area. If a person has a tension pneumothorax, a pleural effusion, a myasthenial mass, or maybe a neck tumor. It's pulled in towards the affected area if a person has had a pneumonectomy, fibrosis, or atelectasis. Should I ask? Anybody know what a pneumonectomy is? Tanya, do you know what a pneumonectomy is?
Like remove your lung.
Yes, ma'am. That's correct. Decreased tracheal movement or mobility may occur with cancer or fibrosis of the myasthenium. And the myasthenium is just the part in between your lungs, with your heart and your aorta, your thymus, and your trachea. And the larynx, guess what? That's done by a specialist, and we don't have to worry about that. Okay. This is the anterior lobes of the lung, which is sort of shows different landmarks where you can find the different lobes on the right and left lung. Remember, there's 3 lobes on the right and 2 on the left. Here's a posterior view. When you look at the lungs, you want to assess the front and back of the thorax. Look at the chest and compare one side to the other. Start at the top, work right side to side, and go down. And look for abnormalities, discoloration, scars, lesions, masses, or spinal deformities. You know, like curvature of your spine, lordosis, that kind of thing. Observe the rate, rhythm, and depth of their inspiration, and symmetry of chest movement, are both sides moving together. An equal expansion. If one side's expanding, the other side's not, it could be some type of disease. And if they're using their accessory muscles, which means they're having trouble breathing. Right. Okay. Look at the shape of the chest and compare the anterior, posterior, which is front to back, to the lateral, which is across. And the normal ratio is 1 to 2. Someone with emphysema who has air trapped in their lungs usually has a more 1-to-1 ratio and results in a barrel type chest. And that would be a 1-to-2 ratio. I'm sorry, emphysema is a 1-to-1 ratio. Normally, your ribs slant downward, as you can see in this picture. But someone with emphysema or chronic asthma that's retaining air will have more horizontal. The ribs will be more horizontal. You want to palpate the chest and assess respiratory symmetry and abnormalities. Look for tenderness and check for vocal primitus. Vocal primitus is a vibration felt on the chest when the patient is speaking, and you can feel this. Decreased movement on one side may be caused by pain, trauma, or a pneumothorax. Does anybody know what a pneumothorax is?
Lung collapse.
Huh?
Your lungs collapse.
Correct, thank you. Thank you very much. Yes, it's the collapsed lung, or partially, or completely, yes. Respiratory lag on one side may indicate pulmonary mass, a pleural fibrosis, pneumonia, or an abscess. Okay, I'm getting there. Okay, crepitus is air trapped in and under the skin. And it's also, another name for it is subcutaneous emphysema. And this can be felt as a cracking sensation. Primitus is decreased if sound waves are slowed from the trachea to the chest wall. And this can occur with a pneumothorax, pleural effusion, or when the bronchus are obstructed. Primitus is increased with pneumonia and abscesses. Okay. I was going to ask if anybody knew why, but I'll answer that after a bit. Percussion, which is just tapping on the chest wall. It vibrates the structures and produces sounds, which they do have they have a table in their book of the percussion sounds, I believe.
553.
Okay. I'm just going to kind of read through them. Renaissance is a normal sound and is low and hollow. Hyperrenaissance is usually indicates air trapped in the lung and is commonly heard in emphysema or asthma. A flatness over the lungs may indicate pleural effusion. A dullness could be atelectasis or consolidation in your lung. And tympany may be pneumothorax, which she just said was a collapsed lung. Okay, auscultation. You need to listen for normal advantageous and voice sounds. This provides information about the flow of air through the tracheal bronchial tree. Could imply fluid, mucus, or obstructions. Breath sounds are identified by location, intensity, pitch, and duration, and when in the respiratory cycle they occur. Okay, I hope this works. Yes. Okay. Normal breath sounds are, one is bronchial. We're going to listen to these. That's normally heard over the trachea and the main stem bronchi. And then your bronchial vesicular, which is heard over the branching bronchi. We're going to listen to that. Hear the difference? Vestibular. also a normal breath sound. Soft rustling sound. This is over the periphery and the small bronchioles. I thought while we were here, we'd go ahead and listen to some abnormal breath sounds. I'd like to listen to, because we're going to talk about some crackles. Just do some respiration crackles. Now, if you heard that, you probably know something's wrong, right? Yeah. And I wanted to listen to a pearl rub. It's pretty obvious, isn't it? Oh, the wheeze. This you can usually hear without a stethoscope. If you ever heard anyone wheeze. Usually you can hear that with your ear. And one more I want to listen to. Remember I was telling you about stridor usually indicating obstruction? Well, they have stridor on here too. And you can tell this person's in distress. Now, if you heard that, wouldn't you think this person's in trouble? Yeah. Is there any other sounds anyone would like to hear? Is that good? Okay, well, I'm in breath sounds. Okay. And these normal breath sounds can be increased, diminished, or absent. And they use the word normal. I was always taught not to use the word normal because there is no quote unquote normal. Okay, the abnormal breath sounds, which I'm using the word normal in, are called adventitious breath sounds. And there are additional sounds that are heard over normal breath sounds and usually indicate pathological changes. And they have these in two categories as discontinuous and continuous. And then they have a pleural friction rub all by itself. Discontinuous sounds are fine crackles, fine rails, high-pitched rails, coarse crackles, and low-pitched crackles. Continuous sounds usually include your wheeze and your rhonchi. And then your pleural friction rub is kind of in a class by itself. Voice sounds or voice renaissance is normal when it is muffled and unclear. Oh, well, here's the sequence for percussion and auscultation. This is the anterior view and posterior. Posterior on the top, anterior on the bottom. So this is the sequence you should use. You're seeing you're going back and forth, from side to side. Okay. Okay, voice sounds are usually muffled and unclear because they're traveling through air. And air conducts sound poorly. So if they become louder and more distinct, they're most likely traveling through solid tissue or fluid, which, as we know, is not normal for the lung. So that probably indicates something is wrong, such as pneumonia, an atelectasis, pleural effusion, tumor, or abscesses. This table is your, the one you have in your book. It's just your percussion sounds with examples. some of these sounds that are abnormal over the one are normal over other organs, excuse me. Other indicators of respiratory inadequacy, immediate oxygenation problems include cyanosis, parlor, decreased endurance. Of course, long-term clubbing, or long-term problems include clubbing, weight loss, unevenly developed muscles, and decreased endurance. This is a picture of clubbing, and you can see the difference between the normal and the clubbed down. And this is due to decrease in oxygenation. A lot of times smokers have this, clubbing of the nails. They also have weight loss, unevenly developed muscles, and decreased endurance. Psychosocial assessment. If you've ever taken care of anybody with a respiratory disease, you know that, or if you've ever had pneumonia, asthma, anything like that, it's very scary not being able to breathe or get adequate breath. So these people have a lot of fear and anxiety, especially if it's something chronic that they've had for a long time. So you need to talk to them and have them use your therapeutic communication and ask them to express their feelings, ask them about their stress, what kind of stressors they have besides this, and their coping methods. Do they have someone at home to help them? Do they have family? Do they have a neighbor? Is there a support group that can help them? You need to help them to identify current and possibly future sources to identify them with support systems that will help them. It is scary. I've had pneumonia before. Okay, does anybody know the answers to any of these? Okay. We're going to go over them then. Okay, for the first one, air trapped in and under the skin is very good. A fatty protein that reduces surface tension in the alveoli. Good. How about the passageway for both the respiratory and digestive tract? Good, yeah. You guys did your reading. 3 bony projections that protrude into the nasal cavity. Very good. And the tube that connects the nasopharynx with the middle ear. Good. And it's called the voice box. Very good. This is my references. Now how do I get to Jeopardy?
You're right at 50 minutes.
I'm at what?
50 minutes.
Okay. Okay, I'm at 50 minutes, okay.
If you want to show them the crossword,
Oh,
and
yes.
just
that's it.
hit the X at the top of the box.
Yes,
Pass out your crosswords.
Yes, I have crosswords. But I went ahead and printed some out, so I'll just go ahead and pass them
I
out.
put these online last night for everyone, but she's going to give you a handout.
Just pass it on.
She used your terms to know in the back and made a crossword puzzle for you.
I thought it might be a good review for you, and I guess I can go ahead and bring it back the next time so they can check it if more. Okay, thank you very much for your time. I appreciate it. Everyone was pretty good student today.
And tell them about the Jeopardy game that you put on
Oh,
there. You
yes,
might want to show it
the
to
Jeopardy
them.
game online for you. It's review for this chapter. And I actually, if you play it, I would kind of like to know, because I'll be back, what your score is, how you did. This is like a lot of the terms that we use today.
You guys could get in your groups, and I know some of you guys study together. You can use this as a study tool.
You can put some diagnostic on.
She's got some diagnostic labs on here. She says this is on here. You can click on that, and then these are the ones that we've played in Nurse 1.
They're all respiratory.
They're all diagnostic test. So here's your board. You click on that, it shows you the questions, and then there's your answer. And then if you go back and click on the A, go on the A, it takes you back to your board. So if you guys are getting together in your groups, you can play any of this.
Thank you.
That's-